Hello everyone, welcome to my video channel. Today I am going to cover regarding the effectiveness of the external stabilization as emergency management of pelvic ring injuries. We will start with an introduction, then regarding a pneumatic anti-shock garment PASG or medical anti-shock trousers MAST, regarding the pelvic binders or pelvic sheets, anterior external fixation AEF, and lastly regarding the C clamp. As always, the disclaimer is the same in all my videos. Thank you. Now let's begin. As an introduction, among the multiple injured victims of blunt trauma, almost 20% have injuries to the pelvic ring. Pelvic fracture associated with intracranial mass lesions or notable abdominal injuries have mortality rates as high as 50%. The mortality associated with open pelvic fracture has been shown to be 30 to 50%. The parameters that predict mortality are A. Age, B. Injury Severity Score ISS, and C. The existence of severe hemorrhage. Exsanguinating hemorrhage is the major cause of death in the first 24 hours after trauma. Immediate recognition of hemorrhagic shock and effective control of bleeding is important in every resuscitation effort. Volume resuscitation without hemorrhage control is ineffective and may lead to secondary iatrogenic complications such as hypothermia and coagulopathy. Hemorrhage control consists of stopping external bleeding by direct pressure and quick decision regarding whether surgery or other interventions required for internal control of bleeding. First, a thorough and systematic search to identify the source of bleeding. It can be done by doing a plain radiograph of the chest X-ray, and pelvis, followed by evaluating any intra-abdominal bleeding by doing a diagnostic peritoneal lavage (DPL) or a focus assessment with sonography for trauma (FAST) exam. In patients who are both hemodynamically and mechanically unstable and in whom the major bleeding is thought to be related to the pelvic fracture, external stabilization of the pelvis become priority. Because the main sources of bleeding are most frequently the presacral venous plexus, around 80%, and fractured the bony surface, external stabilization decreases the hemorrhage by reducing the volume of the pelvic basin and approximating the fracture ends. We are going to start with pneumatic anti-shock garments PASG. PASG or medical anti-shock trousers MAST may provide an initial redistribution of blood from the limb to the trunk and restrict the expansion of a pelvic hematoma. Randomized trials in multiple injured patients have shown no survival benefit for the use of MAST garment. It is also unsuitable for long periods of application because of the risk of compartment syndrome. It also limits access to the limbs and abdomen, making assessment in emergency department more difficult. Next, regarding the pelvic binders. Circumferential pelvic binders or sheets are gradually replacing the anterior external fixator AEF as the method of choice of immediate external stabilization. Binders are currently a part of ATLS protocol. These binders are non-invasive, simple to apply, inexpensive, and can be applied at a pre-hospital stage. Biomechanical studies with pelvic sheets applied around the greater trochanter and tension to 180 Newton have been shown to increase the pelvic stability by 61% in response to rotational stress and 55% in flexion and extension. It is shown to reduce unstable pelvic fracture radiologically and to improve the patient's hemodynamic status. The potential complications of pelvic binders include skin necrosis if left in place for too long or applied too tightly, in lateral compression injuries with transforaminal sacral fracture. Possible visceral or neural injury may occur if binder is applied too vigorously. In vertically unstable pelvic fracture, a supracondylar skeletal traction pin with weight around 25 to 30 pounds, about 11 to 14 kg of longitudinal traction, will bring the affected hemipelvis down before applying a pelvic binder. Next, regarding an anterior external fixation AEF. Raymer and co-workers reduced the mortality rates from 22% to 8% by adding the acute external fixation to their hospital resuscitation protocol. Based on their result, they concluded that skeletal stabilization of pelvic injury should be viewed as a part of resuscitation rather than reconstruction. Burgess and colleagues documented decreased transfusion needs and reduced mortality with the use of anterior external fixation. Anterior external fixation gives hemostasis by maintaining a reduced pelvic volume, allowing a tamponade, and by decreasing a bony motion at the fracture site, allowing clots to stabilize. Fixator pins can be placed percutaneously or with an open technique. There are two common sites of pelvic pin placement. A. High root, directly between the two tables of the iliac crest, which is more preferable compared to B. The low root, the supraacetabular area between the anterior inferior and the anterior superior iliac spine. For high root external fixator, a step incision is made 1 finger breadth behind the anterior superior iliac spine. The drill guide is placed along the inner two-thirds of the iliac crest. After opening the cortex of the ilium with the drill, a 5 mm threaded pin is directed toward the greater trochanter and inserted into the ilium. Two pins, placed in a converging manner, are used in each iliac crest and are connected by bars. Manual force is used to reduce the pelvic fracture before tightening of the bars, which are positioned to allow access to the abdomen and permit flexion of the hip. This picture illustrates the high roots frame. The pin is placed approximately 15 mm posterior to the anterior superior iliac spine. The risk of injury to the lateral femoral cutaneous nerve is there. For low root external fixator, insertion of threaded pins in the supraacetabular region is performed by using the anterior inferior iliac spine as a starting point. This procedure can be performed either percutaneously with fluoroscopic guidance or by making an incision and palpating the anterior inferior iliac spine. A 2 to 3 cm oblique incision is made approximately 4 to 6 cm distal and 3 to 4 cm medial to the anterior superior iliac spine. The skin is incised and the subcutaneous tissues are spread. The anterior inferior iliac spine is palpated through the incision. This picture depicts the pin placement. 4 to 6 cm distal to the anterior superior iliac spine and 3 to 4 cm medial to the anterior superior iliac spine. The drill guide is placed on the superior portion of the anterior inferior iliac spine. The drill and the pins should aim proximately towards the sacroiliac joint. Drill should be inserted only through the anterior cortex. Using a T-handle, the pin is inserted. The pin should be directed approximately 10 to 20 degree cranially and 20 to 30 degree medially. Advance the pin as far as possible into the posterior aspect of the ilium in order to improve the purchase in the bone. This picture illustrates the pin placement. Pin directed approximately 10 to 20 degree cranially and 20 to 30 degree medially. Anterior external fixation AEF is for open book fracture and the unstable shear type when combined with longitudinal traction. In lateral compression injuries, anterior external fixation shows fewer benefits. Anterior external fixation applied before laparotomy can reduce the further bleeding and prevent hypotension from decompression of the tamponade effect upon opening the abdominal wall. Among the complications of anterior external fixation include 1. Contamination of the pin thread insertion when it is done in emergency department. It is hard to maintain a sterile environment. This will lead to difficulty for definitive care of pelvic fracture. Number 2, the pins can easily be misplaced, which could contribute to premature loosening and mechanical failure. Number 3, difficult to apply the anterior external fixation in obese patients and can impede access to the abdomen and groin. Number 4, anterior external fixation can aggravate the posterior instability in an unstable fracture configuration. And lastly, regarding a C clamp, it is best used for posteriorly unstable fracture. It exerts transverse compression directly across the sacroiliac joint. The average force of 342 Newton can be applied to the area of this joint. Mechanically and technically, a posterior device is better than an anterior one. In experienced hands, the posterior device is faster and safer to apply, and its position can be easily modified to allow access to the abdomen for the general surgeon. The typical site for pin placement to be at the point of intersection of a line from the posterior to the anterior superior iliac spine with the extension of the longitudinal axis of the dorsal border of the femur. Once both pins are placed, the clamp is assembled and can be swiveled on its axis to permit access either to the legs or abdomen. This picture shows the technique for inserting a pelvic clamp. One pin is inserted on each side of the pelvis at the level of sacroiliac joint. This point corresponds to the intersection of the line drawn along the long axis of the femur and a vertical line drawn from the anterior superior iliac spine with the patient supine. Complication of C clamps. Number 1. Dangerous in cases of comminuted sacral fracture. Neurovascular injury can occur due to crushing of the sacrum. Number 2. Pelvic penetration of the stabilizing pins and overcompression of the clamps. The prongs of the C clamp can be misapplied and accidentally placed into the true pelvis through the greater sciatic notch. Oh no. Yay, we have reached the end of the video. I hope you have learned something from this video. See you, take care, and bye.